we had in the last 2 years, on how the SARS-CoV-2 virus infects, the human cell, that it can infect only some specific cells that have a receptor for this virus, and that these cells, are in fact mostly in your nasal mucosal or in your eyes. So based on that knowledge, we identify, like others, that the almost exclusive route of transmission, and particularly in hospitals where we have a lot of hand hygiene, environmental cleaning, and so on, the route of transmission was airborne. And from that, we realized that the best protection against COVID transmission, against SARS-CoV-2 transmission, was really in having a mask, an appropriate mask, and the best being if you have to wear an N95 mask, to have a mask that's been fitted to your face, and to have a visor, because in certain circumstances, you can have splash and droplets coming from a patient that's talking to you in front of you. We found out, that COVID is not a contact. It's not transmitted via contact. There is no risk of getting COVID by shaking hands with a patient that has COVID, and there is no risk of getting COVID via normal contact with a patient. So it's not a disease that requires contact isolation. Knowing that, we remove and we took away some things that we had implemented in April 2020 at a time where we knew absolutely nothing about the virus and its mode of transmission. So we removed the universal wear of gloves and the universal wear of guns. The fact of donning with a gun in the morning and then spending a few hours in the ward and managing all your patients and all the patients with the same gun. The reason why we remove them is that first, they are not a way to protect you against, SARS-CoV-2 transmission. But besides that, by having universal wear of gloves, we stop doing the 5 moments of hand hygiene. And by doing universal wear of guns, we stop doing contact isolation for the patients that need to be in contact isolation. Because they have any other bacteria or fungi that requires contact isolation.
Dr. Mesler?
Our new guidelines, and just for everyone to remember, the transmission is via your breathing. So your mask is going to be one of the most important pieces of equipment. And sometimes you can still have splash if the patient, doesn't wear the mask. And that's where the visor is still an important piece of protection. And everything else is not a protection against COVID transmission. It can still be used in our hospitals, of course, but it has to be task-based. If you think that you're going to perform a task that might expose you to bodily fluids, then of course you can wear gloves, or you can wear an apron, or you can wear a gun. For example, if you have to prone patient, in that case, but you have to discard that piece of equipment immediately at the bedside of the patient. And I'm going to stop there, and I'm going to let Prof. Mehta to take us through the whole setup, because in fact, the PPE is just one small piece of what we can do to prevent COVID transmission. And she's going to explain that to you. Prof?
Thank you very much, and thank you for the invitation. It's really kind of you to ask me. I would just be very grateful if everybody could mute themselves, because we are almost 400 people and the bandwidth goes very quickly. So what I will do is to share my screen, and believe me, I don't have all the answers. I don't think any of us have all the answers. But what I'd like to do, if I possibly can, is to take you through some of the concepts that occurred. Can you see my slide, Mandy? My slides, Mandy? And are they in presentation?
Yes, we can.
And they are in presentation mode. Okay, so the reason I've called my talk What Will I Wear Today is because there is such a lot of choice. Everybody has got their own idea what they should wear or how they should wear it. I would really be very grateful if you could mute yourself, please. Please. Thank you so much. It just makes my life a lot easier. Okay, so what I'm going to try and do is to talk to you about I'm going to talk to you about the new evidence there is on ventilation. And this is really to try and explain to you what's going on globally, but also why we're saying what we're saying and why there has been a change. So the first thing was that initially, this was in March, April last year, when the Ministry Advisory Committee came together and the IPC program came together, and we hurriedly wrote the COVID guidelines. That was related to SARS, not COVID-2, but SARS and MERS. And everything was based on the coronavirus transmission, which of course, as we knew at the time, was droplet. And that was the main emphasis. And even those of us that served on the WHO, GDG, realized that this is what was going on, which is fine. Okay. Since then, the aerobiologists have become involved, and they have brought forward some amazing, fantastic new information. There is a group called ARIA, which I belong to, and we sit and discuss the impact of this knowledge on the way we practice. Okay, so the next thing I want to talk about the hierarchy of controls from the WHO. I'd really like to talk about the mixed messages and what happened there. Why was there such an explosion of strange information? And then perhaps we can discuss the appropriate use of a PPE. My talk is very short because I would look forward to your questions, which I think you can do in the Q&A if I'm not mistaken, Mandy. Yeah. Or you can put it in the chat. All right. So let's see how we go with this. So the first thing that we would really like you to mute, if you don't mind, please. Thank you so much. The first thing that you need to understand, which I think you do understand, but I just want you to sort of emphasize this, is that when somebody speaks or laughs or jokes or whatever else, there is a cloud. It's not droplet and aerosol. It's a cloud. Okay, and in that cloud, you have various sizes that come along. This is a wonderful paper published by Hugo Lee, who I'm his greatest fan. He's the most amazing aerobiologist I know. And what he shows you is that there's let's say a portion that comes out at the point of departure, which also emphasizes the need for masks, of course. And as it comes along towards the person in front, up to 1.6 meters, that then spreads. And because it spreads, we have asked, as you well know, thank you. We have asked that you protect your nose, mouth, and eyes and mucous membranes. And this is the reason why, because it's very clear that the smaller particles, even though we know about the larger particles dropping, there is an increase of 127 portion going along. And there's 28-fold increase. So this flow is what we're looking at if you're not wearing a mask. Okay. The next thing is that if you look at the inhalation risk and the distance, which is short or long distance, the major influence here is the type of ventilation. Okay. So if you've got poor ventilation, those viruses which are more prone to be droplets convert into airborne, because the droplets don't dry up and they move along much further. If there is sufficient ventilation, okay, then even tuberculosis, measles, and chickenpox, which we know are pure airborne, they will actually change. And as the ventilation improves, it matters little, because of course it very much depends on that. And of course, if you're outdoors, which is why it's really interesting why we weren't allowed to go to the beach, this then becomes even better. All right. So the idea is that this is your inhalation risk and this is the ventilation. And between these two, we're going to do a balancing act, whether we do it in the facility or in the house or wherever. This is a wonderful paper that was published by Belan Chanda, and clearly shows the very thing that we've talked about, that over here, you've got a huge ejection with the droplet. And as you get to a meter and beyond, and this is why the WHO has said 1 meter. However, in South Africa, we are saying 1.5 meter and beyond. And the reason for that is because all the big guys have dropped and you're left with the very susceptible, fine ones here. Now, this will then, at this end of the spectrum of 2 meters and beyond, will again depend upon the size of the droplet or the size of the particle. It will depend upon the ventilation. It will depend upon the immune status of the person and whether or not their mucous membranes are protected. Okay. Looking at the fact that we're trying to cover the respiratory tract. Now, this is the document that I wanted you to get hold of if you can. If you're not, it's fine. I'll just go through it very quickly. There is a roadmap to improve ventilation, which has had a huge amount of effort put into it by aerobiologists, infection control practitioners, infectious diseases people, and a whole bunch of us have been involved in this. And what it does is it simplifies the concepts. Because if you remember in the beginning of or the middle of 2020, all sorts of issues were being raised that do we do this, do we do that, do we do that? But what it basically does for you is to say that we're looking at the proper use of natural ventilation, and it very clearly gives you a rate, and this is about 10 to 40 meters per hour, or it is 40 liters per second, or it is air changes, depending on whether you're an aerobiologist or an infection control person. Looking at the air direction and whether this air flows out. So there is no need to recycle air through HEPAs and so on, because the idea is that you move the air out and you bring in clean air, and Bob's your uncle and everything should be fine. Then the next thing that they look at is the air distribution or the airflow pattern. And I will come up and I will add to this that we now know that because of the way buildings are being built, and there's natural and mechanical and hybrid ventilation, for example, in the malls and so on and so forth, a large number of areas which are enclosed spaces, there could be big spaces, small spaces, there could be gyms, there could be malls, there could be intensive care units, there could be whatever you want. A good indicator has been the CO2 monitoring. And what CO2 monitoring does is the higher the concentration of CO2, the less the ventilation, obviously, because when you're breathing out and you've got CO2 in the atmosphere, that will be red. And as soon as the ventilation starts, it goes down to yellow, then it goes down to green. And it gives you a very good visual recognition of what your ventilation is like. They're not very expensive, but they still have not been introduced widely in South Africa. However, they are well worth thinking about. Okay. So that was my first part of the exercise. So what we're trying to do is to set up a ventilation program that is going to minimize the use of all sorts of other funny things that we do. The next point is about PPE. It's really interesting, and I've got some data to show you about this. It does not afford total protection. If you're wearing a respirator and the air changes are 2, you possibly will be sucking in from all sides. If you're wearing a cloth mask and the air changes are 30, you probably will be all right. So what you need to look at is the WHO hierarchy of controls, which I will also go through later on. And these are looking at elimination, which we know about, substitution, engineering controls, which is the ventilation, administrative controls, and then PPE. So for some reason, when there's panic, healthcare workers reverse the pyramid and they go for PPE first and can't be bothered about the rest of it because they are scared, because there's fear to self, there's risk to self. So the whole concept of trust in who is teaching you and what they're telling you becomes a very, very important issue. If the training and the administrative controls are not very clear, and there's a wonderful Cochrane review I will show you just now, there is massive confusion globally, and this is exactly what happened. What you saw, how you did it, engineering controls, your ventilation, your work practice, and of course, then your PPE. So what you're now looking at is information. And the question is, where do we get our information from? And there's nobody better than to see us through the COVID pandemic than Zapiro. He had got the most amazing, amazing cartoons that you could ever imagine. Very sharp person. So here he talks to you about where you get your information from. So he said, meet Denzel, who's a PhD epidemiology from the University of WhatsApp. Then there's somebody else who's a microbial genetics from the University of Google, somebody from the University of YouTube, and then there's somebody from the University of Facebook. And what it basically did was that rather than allowing us to concentrate on the working groups that we were trying to get information for as far as possible from reliable sources and from evidence-based medicine, we were looking at fighting some of this issue, which is really, really tiring and exhausting. The next thing would be on social media. You'd see all these people dressed like this, and therefore we would have people from the unions, not surprisingly, saying, "Look, I mean, why are these guys wearing this, and you're not giving it to us? Why are you not giving us this head to toe with the green cross thing going on here and all the covering from the top to bottom?" Well, the answer to that is that in the beginning, because there was so much confusion and the infection control people, unfortunately, were marginalized and not allowed to be involved, cut and pasting from the Ebola outbreak to the COVID outbreak is what caused this confusion. So everybody was engaged in trying to look like an Ebola person rather than trying to do the other. And since I had worked with Ebola as well as with COVID, it became very evident to me why this thing was happening. There was no information, so you cut and pasted, and sometimes they didn't even, probably remove the references properly. What about the community organizations and the evidence-based guidelines? So very quickly, we produced evidence-based guidelines. And the last one was in June 2021, and we probably will have to update that again, but it's pretty recent, it's pretty good. These were completely marginalized and they were not available. So what you were seeing as healthcare workers causing serious panic, apart from the vaccine story, was this sort of thing. Everybody giving you an opinion about what they thought was about the virus. And this was very unfortunate because it did cause a lot of chaos. So when it comes to the training in infection prevention, this is some data from us from South Africa that we have trained now to date over 1,500 healthcare workers across South Africa. But this is just one group that I'll show you. And obviously the dog doesn't like to talk at all. So the training was received by almost 500. Of these, 21% had received no training. They were just handed something and said, "This is you, this is COVID, get on with it." Okay. What was interesting to me was that even though more than 71% were trained by an outside agency such as ICANN, and WHO had asked us to do the training, and we did, and the infection control practitioners did as well. There was also 30% of people who did not have training from a person who was trained and understood what was going on. I mean, not saying that we understood what was going on, but we knew a lot more what was going on compared with people, supervisors, a medical person who was just wandering around, and the admin. So there was a lot of confusion associated with this. More importantly, which was quite impressive for me, is that 42% of people had less than a day's training. Now, if you're preparing somebody for an outbreak or a pandemic, how do you train them for less than a day? And less than a day is 6 hours. What can you teach them in 6 hours that will make them feel secure in what you're telling them and allow you and trust you to give them evidence? And the answer is no. Only 33%, usually infection control practitioners and some of the outbreak people, got a 4 to 5 day course, which is what it should be, giving them all the information, and some of them were a little bit more than that. But this is what was interesting, that what was covered, not ventilation, not the guidelines so much, but the first thing everybody was talking about was PPE. This is what you do with PPE. Some people were showing each other how to do hand hygiene, which is quite amusing in itself, particularly when they were wearing gloves and alcohol on top of it. Some people were talking about standard precautions, but fewer than the group here. This is 82% out of the 90% actually learned how to put on and take off their PPE. So I'm not surprised that there is shock and concern. And I'm not surprised that people are not happy. Going on from that, the guidelines only 75%. In fact, that meant that 25% of people didn't have any idea what the guidelines were about. And even fewer people had any idea about the ventilation, which to us as infection control practitioners working with aerobiologists was the main way of reducing airborne transmission and droplet transmission. So it was really, really important. Now, these are the hierarchy of controls that I was talking about. You've got the triage and screening at the point of entry, fine, tick. Apply the COVID bundle, which are the public health measures as possible, okay. Isolation and improve ventilation, follow the guidelines, provide leadership, there was emotional support needed, and so on and so forth. And then to specifically inform people what and where and how to use PPE. But what do we find in our training? This was the most used. So PPE, 90, as I showed you, 90%, and 10% less than that was on how to do it properly. 75% on the admin controls, and only 63% on the ventilation controls. And this is why there was so much chaos and there was so much confusion, because there was no way that they were balancing what was going through and what one had to do as a healthcare worker, frontline with risk in front of them. This was never, ever put to them in a clear enough manner for them to understand that they felt comfortable. It's really interesting, but there were more people comfortable with working with tuberculosis because they understood it better than they were working with COVID. And it was quite a tiller for us. So this is the WHO PPE thing that came out in July, and I'm not surprised. They said everybody do hand hygiene. You can wear gowns if you like, because everybody in the northern global north had to wear something on their body, otherwise they felt naked, I suppose. They had to wear gloves, of course, and there were people wearing masks if you triaged, but you didn't need anything else. And if there were suspected confirmed cases, however, if you were going to have aerosol generating procedures, you would actually wear always if you were collecting laboratory samples. And that was what was said at the time in July. Since then, the WHO, and this has been a lot of argument, including the paper that came out from South Africa with Professor Dida, where it was taken to them and they looked at it and they sort of went, yeah, well, we don't know. And, they had to look at it because it was a really well done paper. The recommendations were that the medical mask will be worn because of contact and droplet. Okay, fine. We said, fine, very good. Aerosol generating procedures, yes. Particulate respirator to be worn. But they had to put in this conditional recommendation from low to middle income countries because we said the respirator can also be used instead of a medical mask in settings where you're providing care for COVID patients. And the reason we did this was threefold. My argument was that you are not in control of the ventilation in some of these places. Therefore, there's point two is that the healthcare worker is not comfortable dealing with suspected or patients with known COVID-19. And number three is that you will not be able to get away from giving them respirators because they will not be able to work. And what they land up with doing is they, instead of wearing the respirator, they will be wearing a medical mask underneath and a respirator on top, which means that the seal is really bad, or they will be wearing a respirator and a cloth mask on top. There were all sorts of combinations that I've got photographs of. So finally, it was committed that yes, we can actually do that. But by the way, by this time, South Africa had already changed to using a respirator in all the areas of suspected and proven COVID patients. The most important part of this, which I think we need to think about when we are using respirators, is to make sure that your mask fits properly. Because there's no point in putting something sticky on your face, which then causes a huge amount of problems. It's not giving you the fit. You know how to do the seal check. I'm not going to go through that with you. Make sure that it doesn't leak. So that you're wearing this thing, it does actually protect you. So this is just some studies that we had done looking at people that were infected and not infected and what their level of knowledge was. If they were infected, they were looking at non-AGPs, but many of them were looking at respirators because they had no idea, no faith in what was being said. For AGPs, they were quite happy. A few of them were talking about the surgical mask, obviously, and more for respirators. But what was very interesting to me was that people that were not infected, but were well trained, understood that for non-AGPs, almost 82% of them said we can do with the surgical mask, okay? Gloves and so on were going on, but not as many said, can you see about the respirator? This is really telling. And they also knew that when you go into an AGP situation, you can go for a respirator. And I thought this was really good data, and I hope we'll be able to publish it at some point. The other thing was that looking at the infected and non-infected of non-clinical people, they also had very different training concepts of what was told to them about what they should be using. I don't think this is as problematic, but if they were not infected, they knew what to use and how to go about using it. And this is a really important point that we need to look at. I just want to show you this, where they said, do we have enough PPEs? And everybody said, about, let's say 90% said, yes, we do. And if they were not infected, similarly about 80, 90, 87, 90% said, yes, we do. Okay. But what was very interesting to me was that even though 85% said yes, they were wearing masks over prolonged periods of time, when in fact they should be changing their masks every 2 hours, or every time they take it off, they should put on a fresh mask, which wasn't happening. 1 or 2 people said that we were wearing cloth masks, we had to buy our own. Somebody said no, so we had to buy our own. Somebody was using a cloth mask in that situation. People were microwaving, so the elastic went, and then there was alcohol wipes, which broke through the barrier of the polypropylene spun bond. So there were all sorts of interesting ways of people defending their mucous membranes, whether they had masks or not. And equally with the respirators, 77% said that they had, and 23% said they hadn't. But they were more used to using respirators because almost 30% of them were extending the use. Now, we are used to extending the use of a respirator for those of us that work with tuberculosis, and it's fine. I mean, I don't think there's any problem with that. I think the problem comes in is when we start applying outside agents like alcohol or UV, because that breaks the barrier as well, and then microwave, which stops the elastic from functioning. So there are all these aspects of it, which also were started in the middle of it all. I don't want to go through the gloves and so on, because even though they had a lot, they were using alcohol on the gloves, which is breaking through the barriers, prolonged use, which I'm not terribly happy about. And I totally agree with Dr. Maslow that there is no clear indication or evidence that gloves are necessary when you're dealing with a patient who does not require contact precautions. And this would actually, if you know your 5 moments and you are well trained in the matter, you will be able to protect yourself far better than not. Okay, so I think that's quite important. The other confusion that took place, and I'm almost done, was that people didn't understand the difference between a cotton gown and a disposable gown. Okay, so there were non-wovens and wovens. So many of them were cleaning gowns with alcohol. They were discarding them. Some were with communal use, even though they had lots of gowns. Some of them had it for their own personal use, so they were going from patient to patient with the same gown. They were going into the laundry, coming back. So there was all sorts of very interesting activities. And I don't even want to go with the footwear and the head covers and all that sort of funny stuff that was going on as well. But this is a very expensive exercise. I don't know how much they cost, but I would imagine when I was in Sierra Leone that I know that each of those were costing somewhere in the region of $50 for a gown. So I mean for non-woven. And I think the point I wanted to make was that when you're using PPE, it's quite clear to us that the less you use, the more effective it is, because you cover the essential areas of your body that need to be protected. Okay, so if you're doing contact precautions, there's splash. Yes, you will cover yourself with a plastic apron, a gown, gloves, maybe even a face shield. When you're doing aerosol generating procedures, you might want to wear a respirator and a face shield, even though the flow goes across from the back. It might come back. It's fine. It can stop you getting splashes. If you're not dealing with that, what else do you deal with? And I think this is a very important, it's not, you have to get away from the fancy dress. I am dressed like a doctor, therefore I am. I'm dressed like a nurse, and therefore I am. Okay, so if I'm not dressed in this way, somebody might think I'm somebody else. No, that's not true. I've seen people in full garb PPE taking the waste out from the outside bins into the corridor, from the corridor into the bin, and because that's what was expected of them. So coming back to my penultimate slide is this one about the barriers, lovely paper. Please go and read it about the barriers to healthcare workers, adherence to IPC. And there's a wonderful study that was done looking at a Cochrane review of 36 relevant studies. And for a change, South Africa was also included in it. And what we basically found was nothing which was that we didn't know, but it was well looked at. And that is that healthcare workers felt unsure as to how to adhere to local guidelines when they were lengthy, ambiguous, and did not reflect the national or international guidelines. And this we found in all the guidelines that we found in South Africa. We looked at 5 or 6 of them from either private institutions or public institutions or whatever else is going on. This was absolutely true. People were writing loads and loads of stuff because they didn't understand how to explain it. So they kept on writing and writing and became too long and nobody wanted to read it anyway because they were exhausted, they were tired. And the last thing they wanted was to sit there and read a document. So the better thing might be to do an infographic, I'd imagine. They needed clear communication about the IPC guidelines. This is globally, so not just South Africa. The lack of training, which is what we found as well, about the infection itself and how to use the PPE. So the problem was that when the training was not mandatory, okay, well, we know that our training landed up being mandatory in some ways, but the point was that you give them a huge bunch of guidelines, then they're not going to read them. I'm not going to read them. I don't want to read, when I look at a volume like this, I say, oh yeah, okay, fine. Thank you very much. Can you put it on one page for me so I know what I'm supposed to do? Okay. The lack of PPE, as we knew in the beginning of the outbreak, the provision of equipment that is of poor quality, as we knew in the beginning of the outbreak, was of a serious concern globally. And so this needed to adjust the volumes of supplies as the infection continued. And what was interesting in South Africa, in the Western Cape, we wrote the norms very earlier on. We wrote the norms of what PPE does each healthcare worker need in the PY area and in the other area. Whether it went out, whether it went further, I don't know, but it was definitely in the COVID guidelines. And it was a really good marker so that we would know how much PPE to order and what to do with it. And finally, the importance of including all staff, including cleaners, porters, and everybody else when you were doing this work, which is normal, which is what we normally do. So I'd just like to summarize by saying that there are lots of mixed messages. We don't have all the answers. We still don't have all the answers. We're better than we were, but we are not out of the woods yet. There are non-IPC trained persons who are conducting training during the pandemic. That really confused matters, we found out, and there was a much shorter duration of training. So there wasn't enough evidence given to the people that were supposed to, they didn't know why they were using what they were using. There was certainly a misuse of PPE because of various reasons, and this sometimes increased the risk. We don't know how much increased the risk by, but we do know that if you use alcohol and UV and so on, that it actually damages parts of it, depending on what wavelength you're using. And of course, there was at that time a crucial situation. There was lack of mentorship and support for the healthcare workers. And for every healthcare worker that got COVID or was found tested positive, 10 other people had to go off because of contact tracing. So what we landed up with was that we were down to almost 90% of the population that was supposed to look after healthcare patients had left the building. They'd gone off and done whatever they had to do to protect themselves and to be under observation and so on. So this is one of the things that is going to be coming out very soon, to say, do we really need if they're fully vaccinated, do you really need to go off and self-isolate for 10 days? I know it's good to be away and be with the kids and all that, but in terms of delivering healthcare, is that what you really want to do? So at that point, I would like to thank all of you for listening, and I would like to stop here and return the floor to Dr. Maslow. Dr. Maslow, over to you. I don't know if there are any questions. Oh, here we go. Gosh. Yeah.
Thank you for sharing.
Okay. Would you like me to answer some of the questions in the chat?
Yes.
Okay. So one question is, thank you for all this information. Will someone, it's going away. Will someone please share the resources that Prof spoke of? Yeah, of course we can. If recycling PPE is damaging its integrity, what is the right way to recycle respirators? Well, there aren't any. That's the whole point. The studies that were done initially were done on 3M respirators. Okay, those respirators were redone, or they were recycled in 3 ways. And they actually wrote an excellent paper. In fact, there are 4 papers out now, which if you want, I can send you, which shows which part of the respirator there actually works. So there's filtration, there's breathability, and there is integrity. And which are the ones that actually survived all this stuff. There was microwaving, there was UV, there was boiling, there was all sorts of other strange things. And that is where the damage to the integrity, because inside a respirator is a polypropylene spun bond. And that actually gets damaged, and that's where the problems come in. So we're trying not to recycle. What you can do is extend the use of a respirator, as long as it's packaged properly and kept in a dry environment. I know there has been out of sheer desperation, there has been the use of this and that and the other, but I'm just saying that the evidence doesn't point to that. Okay, and I think that
if I can say something, Prof. Mehta, so you can all see that we haven't prepared, together, because we reuse our mask and we disinfected them with UVC. We use we use specific, robots with specific wavelengths, and we had evidence that it was not damaging the mask, and we had no contamination. So
No,
But
that's
that
I
was,
mean, I'm sure you,
yeah.
but I don't know what wavelengths you're using. Are you using 254?
No, we're using the whole range of wavelengths because we're using xenon pulsed UVC. So I can give you the
And
evidence.
I'm talking about the wavelength that you're using for your UVC. Is it 254?
So it was the whole range, that we're using,
Okay.
not a
I don't know.
specific.
I mean, I'm sure what you're doing is absolutely fine.
Sure.
But I'm
I'm
just
saying that for the staff, because they use reused disinfected, they use their own mask being reused 2 or 3 times.
Why do they disinfect it? I'm not sure. I'm sorry, Carolyn. I didn't mean to argue with you, but
no, absolutely. It's not. I'm just explaining.
Isn't it easier to extend the use of a mask by keeping it safely, like we did for TB, rather than putting it into a UV, a microwave, a boiling, or whatever else?
No, we only did, this. Yeah.
Okay. Well, I mean that I'm not going to get into that because that's obviously a net bank, a Netcare thing. So okay. But we would. The evidence from our end is that we would extend the use as much as possible, and that seems to work quite well. I think if you look at the WHO recommendations, that might be what you'll find. Okay, so then there is also.
Prof, can you hear me?
Yes.
There was a gentleman. There was somebody who had his hand up really early. In the Nirupa Huri.
Okay.
Nirupa, would you like to ask what you wanted? Your question. You had your hand up. I think Nirupa.
Maybe it was a mistake.
Maybe it was a mistake. Yeah. Thanks, Prof. Then you spoke about. Yeah.
Are there any specific PPE guidelines for ophthalmologists examining patients with the slit lamp microphone? The answer is no, because my ophthalmologist asked me exactly the same question, and the answer is no. They use the same. They use a respirator and they use a face shield. I don't know if you have any other ideas that you want to perhaps put out, but the ophthalmologists from Europe and the United States were happy with that. Ours were happy with that as well, I think. But I don't know, does anybody else have any ideas? Please, if you do, please do come forward with them on the ophthalmology side. So when treating COVID patients, should practitioners perform aerosol producing procedures wearing a gown? Okay, good question. I mean, there is no evidence that it'll prevent you getting the, if you protect your eyes, nose, and mouth, that you might get something on your body, you think, from the aerosol. It's quite possible. Like I'm saying, I've said this over and over again, and I say this to every healthcare worker. If you're not confident in dealing with the patient, you give them the worst possible care because you don't want to be near that person, okay? So if you feel a lot better wearing a plastic apron while you're taking a swab, fine, honestly, fine. It only costs 20 cents or something, for heaven's sakes, that's not the bit that we have to worry about. We don't always have to regiment, to be in a very tight regiment, because it doesn't work for some people. But you must also, at the same time, as healthcare workers, apply your knowledge. So if you're concerned that you're going to be covered in somebody coughing all over you, by all means do. But you still need to protect your, I mean, I do this all the time to my students. This is what you have to protect. Your eyes, your nose, your mouth, and your hands. That is what you have to protect. The rest of it, we know that the virus doesn't survive very well anyway, so outside the body. Okay, so I think we need to just think that through. I like what Prof mentioned. I have a one-page information sheet. Okay, that's it. Healthcare workers like physiotherapists who are in close, often in contact with confirmed COVID. Are we safer if we have a respirator? Look, the respirators are now for all people working in the PUI and in the COVID wards. Okay, that has been since September. I think that is right, isn't it? So since September, across the board in South Africa, we've moved to using the respirator. That would include physiotherapists because you're up close and personal with these people. Am I right, Carolyn? Is that
absolutely? And we even extended the use of N95 to the physiotherapists in the green wards.
Yeah, that's it.
Same as ED staff too, because they never know who they have to deal with.
So anybody who goes into that environment, into that area of the green air, whatever wards, okay, who have possibly in contact with, knowingly or unknowingly, with COVID cases, should wear the same PPE, right? Unless you can guarantee to me that your ventilation is sitting at 24 air changes an hour and it's extracted ventilation, then you can walk in there with nothing and say, hey, I'm vaccinated, I'm fine. The answer is no, no. You're going to wear what is required of you. And I would imagine at this point in time, you're required to wear a respirator. If you're going to do physio and doing chest physio, you probably like to wear a face shield, okay? And if you choose that you feel better wearing a plastic apron, or you want to wear a gown, okay, fine, it's up to you. But, the fact of the matter is that the main thing is you protect this. This is what you need to protect, okay? Mr. Huri said, can we enforce that COVID-19 patients actually wear their masks in hospital? Okay. COVID-19 patients complain that healthcare workers are not at their beck and call, but never have their masks on when you go to cubicle. Okay, if you don't want to wear a mask properly outside, why would you? Okay, so I think we need to not blame. If the rule is that you come into a ward as a patient, you will wear a mask. Okay, the patient will wear a mask if they can tolerate it. I mean, the chests are terrible, they can't, well, they can't. They will wear a surgical mask, okay? We're very clear about that. They need to wear a surgical mask. If they physically can't cope with wearing a surgical mask, okay, that doesn't mean they shouldn't be given care. You can walk up to them and you can talk to them without them having to feel like piranhas. Like pariahs, you don't want to do that to them, yeah? So if your rule is that you will wear a mask, which it is because we're looking at mandatory masking in South Africa, including wards and clinical areas, then that should be fine. And you can say to the person, listen, I'm really sorry, my darling, but would you mind wearing this? Because it's not just about you, it's also the people on the other side of you and on both sides of you and also me and everybody else. So just, just put it on and that should be fine. I don't know if that answers your question. Are there any new considerations of use of PPE? Oh, yeah, okay. Now this is a difficult one. The first round of advice given to the Department of Education was that, this was in last year, that the children under the age of 6 do not transmit. Okay, so that went out the window as we know now, So children under the age of 6 do transmit, and that adults would have the same viral load as the 12-year-old kid has the same viral load as the adults have. Okay, so therefore they would be wearing face cover. Under 6s is a difficult one because to manage an under 6 with the face cover is not the easiest thing in the world. So many countries are now going towards vaccinating the under 6. I mean the 5 and up, so that they can allow them to just have a face shield. Now many kids don't like the mask because they, it takes away from their connection with the rest of the world. So they much prefer a face shield. And some institutions are allowing, particularly in the global north, are allowing children under the age of 6 to wear a face shield. Okay, so I think that's really quite a difficult one. And I think we're going to be discussing this on Tuesday. The problem that's happening in the Department of Education is that they want to move the children closer together. And I'm not really happy with that. So they're saying 1.5 meter, but no, sorry, Prof, we want to bring them 1 meter. I'm saying, oh God, please don't, not in the middle of this new Omicron variant, please. I mean, we're trying to get space between the people and so on. So yeah, that's a little bit of a problem. But I don't know myself. What have I done? Okay, so I don't know the answer to that, but there is guidance. There are advisories about masking of children under the age of 6, and unless it's changed in the last, let's say, 8 months, then they would be wearing them. Okay, so somebody says, is aerosol generating procedure a proven concept in December 2021, but still assumed to be concept of fear? No, it is a proven concept. definitely a proven concept. Aerosol generating procedures have been shown now. I think I showed you, I maybe not have showed you Linda's slide, Linda Mroska, who is also a most phenomenal aerobiologist. I mean, she's brilliant, brilliant, brilliant. She actually showed what the movement was of droplets and aerosol coming out of a person that actually, because there's the same effect as poking somebody's throat and they cough. So that it goes much further. So instead of going to 2 meters, it can go up to 4 meters. So the answer is yes, it is definitely a very proven thing to happen. You're welcome. Okay. Should we wear scrubs at all times instead of normal clothing? I can't really answer that. I mean, many people do. They wear scrubs because they are in a work environment and that is their uniform. What you do with it afterwards is then again a moot point, because either you take it home and you wash it, or you leave it behind and somebody washes it for you. But by and large, many high-risk areas would expect you to wear scrubs, okay? But I think that'll have to depend upon the policy of the healthcare facility that you're working in, whether they think you should or you shouldn't. Many public hospitals would not be wearing scrubs in the COVID and the PY wards because, you know, they don't. I know the ID boys don't. They don't like to wear scrubs. So that's something you need to think about. We have to be absolutely certain that the engineering controls and ventilations are in accordance with accepted guidelines. It is natural to feel insecure if we are offered less than what we are accustomed to. Okay. Patients often don't wear masks and do cough while you examine them. True. All you said is true. But what I'm saying to you is that your engineers, which I'm sure there are many in your establishment, have got a duty and perhaps even a protocol where they come in and they measure your airflows every month, and certainly do in other organizations. And they can use an anemometer, or like I suggested, maybe you can think about acquiring CO2 monitors and sticking them on the wall, and they're really cool and they work and they're visual. You can see the green, yellow, and red really, you know, really quickly. So that is good. I'm going to stand back and say I don't want you to blame patients, please. Okay. I think it's really important that we don't blame patients because we're all in it together. So it's not their fault that they've got COVID that they're giving to you because you're not doing what you're doing. This is really not going to work. And that's not what it's about. Okay. It's about what do I do in a given situation to the best of my ability so that I can reduce transmission to myself and my family and to the bloke that's lying in the bed who I'm supposed to be looking after. So I think if they have to wear masks in hospitals, they should wear masks, you know. Somebody called Nathi Khandla has raised a hand. Can I answer your question first before I go on to the other questions? Did you have a question?
It was actually more a comment, Prof, rather than a question.
Please.
Or a few comments.
Yes,
okay, I'm just as well. Thanks. And thanks for Netcare for organizing this meeting. And I think to you, Prof, first of all, just to thank you and commend you for going back to reminding us that patients are not to be judged, but we need to actually treat them with the utmost respect and appreciating that at the end of the day, they with us looking for help and how we manage them is actually should be sensitive at any given step. My comments, so I'm an anesthesiologist and intensivist, and I used to, I was the head of ICU at Dr. George Mukhari Hospital in Gauteng, but now I'm in private practice at one of the Netcare hospitals. And there's a few observations that we've made, and I'm glad that actually you've confirmed a lot of them for us that we change as we moved along. I mean, the first thing that I wanted to comment about is that medicine by nature is actually a risky profession in terms of if you're dealing with a pathogen of this nature. And to have zero risk is obviously not possible, but you obviously try and minimize the risk as much as you can. And I think that's what we actually covered. And I think most of us from the beginning, and I think Netcare at the beginning took the same stance, it was actually to focus more on the broad part of the pyramid that you projected. But I think for most of us and everybody, naturally, when we're all scared and out of fear, and seeing what was happening overseas, everybody rushed to having obviously as much protection as possible in terms of PPE, hazmat suits, and so on and so forth. But unfortunately, I think that in a way over time, just because it sort of went against known science, has probably created more sort of problems, because to reverse it becomes a challenge. Even if evidence comes up to say, let's revisit and go back to what you knew before, people just feel like, but this is what we're comfortable with. And not to drag this long, the other thing I wanted to comment about was, if you look with every new wave of all the waves that we actually had, and I noticed this in our hospital as well, from sort of second, or even the first, second, and third waves, and I'm noticing this in private practice now as well with the fourth wave, is that most of these infections actually come initially from the community. We are at this stage all focusing on what's happening in the hospitals, and we are trying to almost stop a best bridge, or so to speak, at a place where probably the impact is going to be less. So most of this starts in the community, and most of the people, and if you look now, probably in most hospitals will find that it's mainly staff that come in with something, and some patients obviously who have been screened, they've been tested, and we've done everything to make sure that they were not positive, but the other 10 positive in the wards, or staff actually gives to them. So that's actually an infection that's happened in the community setting. And what then tends to happen is that if you have an ongoing COVID ward, so in our hospital previously, we had designated spaces for COVID, even out of the waves, those remained. You would find that the COVID wards will only have the patients being the ones who are positive. And yet in the normal wards, where everybody's guard is down and there's no focus on sort of the other peripheral issues, they then would actually have the spikes of infection initially. But as the wave progresses, that obviously self-attenuates. And then suddenly those wards clear out, and then suddenly you get more increases in patients in the COVID wards. So I think we need to also return to that part of actually ensuring that we speak to people about what they do outside of the hospital, and not having so much, similar emphasis as to what happens in the hospital setting. But for me, that's where I think the so-called normal wards, where people feel less secure, is probably the most dangerous space. And lastly, it also speaks to the physiology of COVID. So obviously we're changing strains. I mean, I'm not sure how that changes, but personally, I do not think that one has to make different rules for every strain that comes up, but we might need to. But we've learned a lot up to now. And my perception so far is we know how the disease spreads and how long people are infectious and so on. And I used to find that like people pay a lot of attention in the COVID wards. And interestingly, that's probably, if you speak to most patients who are there, it's probably the least infectious people, because they're way beyond most of the time 2 weeks and so on. But that's where we are more worried. We want to go in there all covered up, and they probably are the least infectious. And actually, in fact, in our wards, we didn't force anybody to do that. But personally, I seldom actually wore full PPE and actually gloves and interacted with patients to limit actually spread. Thanks.
Thanks,
Thank
Dr.
you very much.
Appreciate it.
Thank you,
thank you very much. Can you take a few other questions?
Can I just respond to that very quickly in a couple of sentences? I totally agree with you. I think what you've said is absolutely right, but we all know that transmission, 90% is in the community. We know that the infections that happen in the healthcare facilities happen in tea rooms where everybody dropped their guard. We know that. We also know from Ebola and from COVID that transmission of COVID during the waves in particular happened where people were not looking to, there were non-COVID hospital wards. So all the things that you've said is absolutely true. So I think that's very helpful to know that, that there's recognition thereof. Sorry, Mandy, I'm going to go on. And there is one question that if you wear a long sleeve plastic apron in a COVID ICU during a ward round, does one need to change that? Yeah, I think the issue around long sleeves, as we know, is different in the sense that infection control prefers not to have long sleeves. And the reason is because the edges get contaminated here and here. And so when you're putting on your gloves or taking off your gloves or touching a patient, you do contaminate them. So we're rather more partial to plastic aprons that are sleeveless, if possible. and with your sleeves rolled up. I don't know what the Netcare regulation is, but I think that's as close as well.
That's exactly what we're saying, is that we've seen an increase in other infections because they feel that wearing a plastic apron is appropriate between 4 or 5 patients. So we are not a plastic apron, long sleeve. So we are also saying no more long sleeves. And if you do wear it, you've got to take it off straight after the task and move on to the next patient.
Thank you, Mandy. That's really kind. Very quickly, I was going to go to the radiology staff are asking about PUIs and so on. I think the radiology staff are, even though they're not in the ward, they are clinical staff and therefore should be considering the use of respirators for their patients, because we really don't know who's coming to you for what purposes. And very much the same as in a clinical environment indeed. So I would strongly recommend that you seriously consider wearing your respirators. And since you don't have any coughing and spluttering going on, you may not choose to wear a face shield, but certainly I would suggest that respirator. Okay. Should healthcare worker wear respirator in a non-COVID ward, and is there a surgical? No. Now this is a very interesting one, because somebody, Erica, if you don't mind, would you mind muting yourself if you're chewing? Thank you, Erica. Thank you. That if you're in a non-COVID ward and you wear a surgical mask and you're not doing anything to a patient, then there's no reason for you to be at risk, to be honest. Okay. And because if the person, now again, we come back to this thing, there's a patient wearing a mask, and are you wearing a mask? And the patient should be wearing a mask on a non-COVID ward more than ever, because all patients are supposed to be wearing face covers. So that is definitely right. So therefore, the risk there is much, much lower. There hasn't been any evidence whatsoever to say that you need to wear a respirator when you're on a non-PY or COVID ward. All right. But a face cover, definitely, surgical mask, definitely. And I would advise that. I don't know what everybody else thinks about that, but that would be interesting. With the mutations in Omicron variant, can we assume that previous experience and data with the other variants are that? Yeah, absolutely. Okay, so let me just explain the beauty of infection control. We go by transmission routes. We don't go by amby-pamby fancy stuff. The route of transmission is via the respiratory tract. Yes? Good. Therefore, you will protect the respiratory tract. That's it. So it doesn't matter which one it is. It doesn't matter. You might go from a mask to a respirator, perfectly fine. You're still protecting the respiratory tract. You might add a shield, perfectly fine. You're still protecting the respiratory tract. Again, I'm going to do this just to embarrass everybody. That's what you need to do. That's what you need to remember. And that's the way it should do. Oh, okay. Debbie wants a recording. Can you please stay mute? Okay. Then in previous waves, we were told not to prescribe nebulized medication. What is the guidance currently? You know, I don't have any cooking clue about that. I really have none. But I do know that in the neonatal unit, they were using spaces. Sorry, Carolyn will help. Yes, please.
Yeah, if I can help here. We didn't say not to use prescribed nebulized medication. We said that we wanted to avoid to do them in multiple bedrooms, because you as healthcare workers are wearing your protection. You are wearing your mask or your N95, or you are wearing your surgical mask in your visor. But very often the patient in the next bed is not wearing anything. And that was a risk. And we had some outbreaks because on the other patients of the room, because that patient, which in fact was a false negative, you know, and so on. So it's not that we never ask not to prescribe any nebulized medication, but to avoid to have patients that needed this kind of nebulizations in multiple bedrooms for the protection of other patients.
Yeah. I think we were using, for the neonates, we were using spaces, and wherever possible that was being used. But I think, you know, I'm sorry, I'm not qualified to comment on that. Is it safe to see a green patient? What, as in somebody from Mars, or a person that's not COVID? We're seeing a COVID patient with the same scrubs. Yeah, it's fine, because there is no contact. If you've had close contact with the patient, yes. Just to remind you that the transmission is via the respiratory tract and not through clothes and so on, as was previously purported, which is why we are suggesting that you don't need to wear lots of gowns and gloves and all sorts of other things with it. So it's perfectly fine. You could wear a plastic apron if you're feeling uncomfortable, and then change it between each patient, and that should be fine.
And Prof, I also commented, wash your hands.
Absolutely, absolutely. That goes without saying. If you don't do moment 5, you shouldn't be going near another patient.
Absolutely.
Or moment 1 even. Okay. Thank you for that. Okay, then the advice regarding numbers allowed in venues for social distancing. This is really interesting. I was when I was serving on the Ministry Advisory Committee, which now I'm supposed to be off it, but I keep hearing from them all the time. I would like to see venues at 50%. The 750 in-house, and I'm of South Asian origin, and we have a tendency of getting very amorous and very, very, when they say a small wedding is like 350 people, so everybody's on top of each other and so on. So what I would like to see is that a venue should provide only 50% of the total capacity. And the reason for that is because it allows you to increase the ventilation flow. It allows you to improve the airflow also. So you've got all the windows and doors open, you've got a tent or something, a marquee, and then you've got lots of air flowing through, then that will be perfectly fine. The best thing is to go and have a beach wedding. That'll be perfect. Everybody go off to the beach. It'll be absolutely wonderful. Lots of healthcare workers see scrubs as PPE, interesting, and then don't wear the appropriate PPE, which is an apron gown, when doing specific tasks. They feel protected. Yeah, okay. Yeah, you're welcome. Okay, that was just a statement. So nebulizing is a procedure of giving medication under pressure. That's right. So that is why aerosolization does happen. Yeah, that's why they use spaces. Thank you. Okay, then thank you. Okay, then please advise on the use of rapid antigen tests during the wave. Positivity rates are high. How should I treat a patient with a negative antigen and a positive PCR? That person is positive. Your PCR is your gold standard. The LFNs have been a big problem. They've been giving false positives in Europe, particularly at the airport in Heathrow. They had to detain about 11 people this morning when the LNFs turned out to be positive and the PCRs turned out to be negative. So your gold standard is PCR. Please remember that. Unless a virologist shoots me and says, no, it's different, but that's what we would go with.
Maybe to the virologist, if I can say something, Prof. Mehta.
Yes.
We use the antigen a lot for triage. Yeah. We are talking about two different things. We are talking about triaging patients so they don't stay for hours until we wait for a PCR result.
Okay, so they go home.
The PCR is the gold standard to make a diagnosis, but doesn't tell you if the patient, it's not as good as antigen to tell you if the patient is more likely to be contagious and need to be in a COVID ward or not. So
in Netcare, you do an antigen as you come in, which will a lot of
triage triage the patient.
Okay, no, that's fine. That's fine.
Yeah,
that's fine.
And then
I would agree with that.
Absolutely, and so that stops the queues and so on everywhere, and we can triage the patient very quickly, especially in terms of search, where we have a good pre-test probability.
Yeah, but what I think the question was, how should I treat a patient with a negative antigen and a positive PCR?
They know about that. It's a patient that has COVID, but is not contagious anymore, most likely.
Yeah. Okay, so then we have, can the COVID patient be admitted and treated in single cubicles in a non-COVID ward? And the same sisters take care of both COVID and non-COVID patients. Interesting. Okay, so the first thing is that if the cubicles are properly ventilated with good negative pressure ventilation, then the answer is yes, because there will be no leakage into the corridors and into the surrounding wards. The person that goes to see these patients will be wearing face covers and I would imagine a gown or a plastic apron. And when they come out, they will discard that. Okay, but it would not be wise to move from one person to the other with the same PPE. Obviously, we know that, we've said that in the past as well. So the question is that if you're wearing a respirator and you're going to a COVID person first, then would you be still wearing your respirator when you go to the non-COVID person? And the answer is no, because you should have taken it off by then. Okay, unless the person is a PUI, in which case you'd keep your respirator on. I mean, that's the sort of thing I would do personally. But the other thing I would do is, if possible, I would go to a non-COVID person first, and most likely see the COVID patient last of all, and then get rid of whatever it is that I had to get rid of regarding PPE and so on, in case the ventilation isn't as good as it should be. I hope that makes sense. We never hold back care despite patients not complying with mask wear, but maybe the risk to healthcare worker would be reduced to the patient wear mask, especially the ones that are mobile and understand. Yeah. That's fine. We will not take any further questions. Okay, thank you, Mandy. It's 7 o'clock. Yes. Okay.
Yes.
Okay.
Maybe
So,
I can add.
Please add,
here.
Carolyn. Yes, do add. Yeah, do add.
Yes, I said that, we have some issue when before we are at the top of a surge and the wards are full, and when we have 1, 2, or 3 patients, because we found if we and in these cases we advise the hospitals to have the COVID patient when you have very few patients, instead of blocking a whole ward and blocking all the other beds, that it was possible to have your patient in a negative pressure room, in a negative pressure cubicle, which is of course checked and that we know that it's a negative pressure, that we could have the patients, in these rooms, in the green ward. That because there was negative pressure, the COVID won't get out of the room each and every time you open the door. In terms of PPE, it's your mask and your visor. I'm not sure you really need to change your mask if you are managing 2 or 3 patients, one being COVID and the other ones being COVID. I don't think that anything from your mask.
So you're suggesting that they can wear their masks if they're going to non-COVID patients as well.
And then because I don't see how even if there's some COVID on the mask, it shouldn't go on any patient or environment from the mask.
I don't mind. I mean, to me, it matters little, to be honest.
And aprons, of course, aprons have to be changed in between each and every patient. So it has to be discarded in any case. So we thought, and we've been doing that, in fact, since the beginning, because we didn't have any other options.
What I think might also help a lot, if you want to carry on using the same PPE, is if you go from the non-COVID to the COVID patient.
Yes, no, of course. But
So
I don't think, especially in maternity wards, for example, where they can keep, the COVID mother, if one non-symptomatic, mother is coming for C-section or to deliver, she can still be in the maternity ward. It makes it easier than putting her in the COVID ward, far from the maternity. And it's making it easier to manage, for the staff. And that's, but of course in negative pressure rooms, not anywhere, not mixing patients in the ward.
True. No, that's good. I was just going to end by saying that, I hope I've made it clear that we are supplementing very good ventilation with some face protection, which is what the whole concept now is for COVID. Okay. And that, despite the fact that everybody was overdressed and they didn't know whether they were coming or going, that has really helped a lot, because the less PPE you wear, the better care you can give, because you feel more confident in dealing with the patient. All right. Having said that, your respirator must have a good seal. Really, it must have a good seal. Make sure you've got the one that fits you properly. Okay. Try not to wear it around your neck, because that's not where your nose is. Your nose is up here. Okay. So don't wear it down here. Or don't wear it on your arm or somewhere else. Just wear it where you need to wear it and look after it, and that should be fine. I just hope that it was clear. There were some, like I said to you earlier, there's some areas I don't know anything about, or that we have little information on, and there are other areas that we know a bit more about, and we're prepared to go down the path. There's some changes going to take place in the next 2 or 3 weeks to the guidelines. I know you don't use the national guidelines. I know you use your own guidelines, but I'm just saying for general use, those guidelines are going to be modified. And also the whole concept of wearing a lot of body cover should be reconsidered very, very carefully, and whether you need it or you don't need it. Okay. And I think thank you very much.
Prof, in
And
fact,
then,
won't you put your hands up again so I can take a good picture? Hold it there, hold it. We're going to make a poster out of this, Prof.
oh my word.
Thank you.
Take my glasses off. I'm gonna take my glasses off.
You can, Prof, if you want to. You can take your glasses off.
Yeah, no, but I think really, the other thing I'm going to recommend strongly is if you get a chance, please see the donning and doffing video that Professor Mark Mendelsohn has made. It's very simple, it's very straightforward. It gives you a very good idea of what to do, how to do it, when to do it, and not get, confused about what. The one thing we found out from our survey was that people were very confused. They didn't know to take the glove off first, to take the mask off first, to take the, they were really confused because they're wearing so much. And they were following the Ebola protocols, which was the worst part of all. I mean, in the beginning, we had to stop them standing in chlorine and spraying people with disinfectant and God knows what else, all sorts of silly things going on. So yeah, okay. So if there are no more questions, Caroline, it's over to you again. And Mandy, thank you very much for monitoring and making sure everybody was in track. But I'll hand back to Caroline and.
Thank you very much, Prof. I do want to just take 1 minute to just correct something. The Netcare guidelines are definitely based on the national guidelines.
Okay.
So we have never written a guideline that is that does not speak to the national guidelines. We've just put it into the Netcare one. So we have supported the national guidelines.
That's brilliant.
And we'll continue to support them. With a reduction in PPE. Caroline,
yes, that's also what I wanted also to highlight is that we are following the national guidelines. I think the only difference we had initially were the use of N95 in the COVID wards, but exactly for the reason that you mentioned is that many of our ICUs are open plan with very poor ventilation. We did our utmost to improve the ventilation, but we have some hospitals which are old. And we have open plan, and you would have 20, 30 patients breathing COVID, in this ward. And at the time, we thought that we were not sure enough about our ventilation just to provide, surgical mask for the healthcare workers that were working for hours in this ward. That was the only change.
Sorry, I'm just going to say, you don't have to. These are guidelines, are recommendations. Your work practice obviously they're based on those guidelines, but your work practice might need tweaking of those guidelines to fit in with your type of practice. And I think that's a very important point to remember. You don't copy and paste guidelines. You don't copy and paste recommendations. You use what is effective, which is evidence-based, and then you apply your own data to it and say, okay, this is the way it works for us. This is what we're going to do. So it wasn't meant to be a criticism. It was meant to say that you don't have to be, dogmatic about it. And this is something we've had to do with the state sector as well. Saying, please don't keep on going on about this. You have to apply it as it applies to your circumstances, Don't just say, oh, well, I can't do that because it doesn't exist for us. So I think it's just really important that we get that. Thank you.
Caroline, will you close, please?
Yes, so thank you everyone for attending. Thank you, Prof. I think we learned so many things. I think that was really, really useful, and you can see, in fact, the success of this webinar. And I think we will call you if there's any change in the guidelines, or if we need more interventions, or to assist us, in some, difficult, situation.
It's a pleasure. It's a real pleasure. It's a real pleasure. I also have a tendency of being quite controversial on purpose. I do it on purpose.
Yeah, but I think we kept most of the people up to the end. So I think that's also a great success.
Okay.
Okay.
Thank you.
Good evening, everyone, and thank you. Thank you for attending.
Bye.
Bye.
Thank you, Prof. and Caroline and Mandy.
Thank you, everybody. Thanks a lot. Bye.
Bye.
Thanks so much.
Thanks, bye.